Well, greetings, fellow ICS members. My name is Melissa Kaufman. I'm a reconstructive urologist from Vanderbilt University in Nashville, Tennessee, in the USA. I'm here along with my esteemed colleague, Professor Tufan Tarcan from Marmara University in Istanbul, Turkey. And we look forward to engaging with this live opportunity to discuss the contemporary role of urodynamics in female incontinence. Now, Tufan and I will be expanding upon our prior series of urodynamics under the lens, which explored not just the landscape of urodynamic utilization and best practices, but really began the conversation regarding high-yield patient scenario-based management. So our hope is that through a combination of didactics and case presentations and audience polls, you are going to bring to us pertinent questions, perplexing cases, or even innovative strategies for us to all discuss together as collaborators. Because in the conclusion, our combined efforts are so much more powerful to impact the patient and that we may see in the clinic room today or tomorrow. So we look forward to your participation and welcome this opportunity for us to learn from each other, which is really what the ICS is about, right? So we advance our shared goals of optimizing our functional studies, such as urodynamics, so that we can make our first therapeutic decision our best decision. So overall, in this scenario, we have a chat feature, and I see someone is already utilizing this. That's perfect. We have a Q&A, and we're going to pause during many parts of this in order for you to bring forth questions or cases, scenarios, or new strategies for us to utilize. There'll be a poll, and so the poll will be displayed, and you're going to select an option, and these responses are completely anonymous. So we look forward to hearing what you think. It may drive some future thoughts about how the rest of your ICS colleagues are looking. I want you to know that a recording of this will be available for viewing within 7 days, and your feedback is absolutely critical for these initiatives. These are my conflicts of interest, none of which are really directly related to this webinar because we're doing this as your fellow ICS members. And Tufan's as well,
Thank you
including
very much,
serving as
Melissa.
the chair of our Urodynamics Committee and the Secretary General-elect for the ICS.
Melissa, thank you very much for this great introduction. It's a great pleasure for me to be, especially in this webinar with you. I would like to welcome everybody who is listening to us from everywhere in the world. I would like to say welcome. And as you said, please do not hesitate to ask us anything so that we can have a fruitful discussion in our webinar. So our topic is about the urodynamic studies in female urinary incontinence. We know this is a controversial topic sometimes. Just before we get into the topic directly, just remind us of some basic information. So when we just talk about urodynamic studies, what do we mean? The ICS standard urodynamic testing, what we also call as sometimes as invasive or sometimes as multi-channel urodynamic studies, include basically cystometry and pressure flow study, which are usually preceded by free uroflowmetry and post-void residual urine measurements. But the urodynamics are never alone urodynamics. The ICS standard urodynamic protocol mandates actually a clinical thorough history with validated symptom and bother scores, with noting the medication list of our patients, a relevant clinical examination, and whenever it is relevant, at least a 3-day bladder diary, and as we said, a representative uroflowmeter with post-void residual urine before completing the ICS standard urodynamic testing. So our topic today is the urinary incontinence in women. And when we see in our clinical practice a patient with incontinence, this ICI algorithm just tells us to just basically classify the urinary incontinence in three groups. These are incontinence on physical activity, incontinence with mixed symptoms, and incontinence with frequency and with urgency. And of course, we have other types of incontinence, like overflow of incontinence or incontinence related to fistula or other reasons. But the majority of our patients actually present with either mixed type of urinary incontinence or stress or urgency type of urinary incontinence. Then, according to the algorithm of the ICI, these patients should undergo a thorough clinical assessment, including the symptom assessment, physical examination, urinary analysis and cultures, and also assessment of the pelvic floor function and assessment of post-void residual urine. And then we have a working diagnosis in our hands, either stress incontinence, urgency incontinence, or sometimes mixed incontinence. And the general consensus is to start as the first line and second line treatment with conservative options such as physical therapy, lifestyle changes, dietary modifications, and pelvic floor exercises, and also with medical treatment as the second line, especially in patients with urgency urinary incontinence and in some patients with urge predominant urinary incontinence. Usually, urodynamic studies are spared to the group when we fail with our first and second line treatment options before performing irreversible or invasive treatment options. Please note with this red rectangle here, that indicates the complicated incontinence. This complicated incontinence patients include the ones with recurrent incontinence or incontinence associated with pain, hematuria, recurrent infections, significant voiding symptoms, pelvic irradiation, radical pelvic surgeries, suspected fistulas. These patients are, of course, prone to an early evaluation with urodynamic studies and also cystoscopy. And when we perform urodynamic studies, we may face different urodynamic diagnoses in our patient group, such as urodynamic stress urinary incontinence, sometimes urodynamic stress urinary incontinence together with detusor overactivity incontinence, or detusor overactivity incontinence alone, or incontinence associated with poor bladder emptying. And this specific urodynamic diagnosis is the most objective assessment for us in our patients. So this is usually what the ICI algorithm tells us in the management of our patients without going too much into the detail. Melissa, what would you like to tell us about the AUA and SUFU guidelines in this regard?
Thank you so much, Tufan. So much like what we see with the ICI guidelines, the American Urological Association guidelines specifically allocate for complex situations and when we should move forward with therapies. But, I often hear reflection that our guidelines from the AUA tell patients and tell providers that they don't need to undergo sophisticated diagnostics before undergoing interventions for stress incontinence. And I wanted to touch on why that is, why that was incorporated as part of these guidelines. And our guidelines are based to a degree on a study that's called the VALUE study, which is really designed to determine the impact of preoperative urodynamics on a set of uncomplicated stress incontinence patients. Now, this was a very well-designed multi-center trial who compared women who underwent just an office evaluation randomized to women who underwent urodynamics. The outcome was treatment success, but it was only measured by a patient-reported outcome, so not an objective measure. But let me reiterate, the patients in this trial were patients with completely uncomplicated symptoms of stress incontinence. And really, in my practice, this is a really relatively rare clinical situation. So when we're really discussing true value in medicine, this is an equation of high quality with low cost. there is minimal value for women in failing to appropriately diagnose a pelvic floor disorder, which would then result in subsequent invasive treatment, which would not be successful for cure, but may actually exacerbate their condition and lead to the need for further interventions. So our guidelines are clear that judicious use of urodynamics is appropriate and should be employed when there's not an absolute clarity to the diagnosis prior to an invasive intervention. The optimal approach really is personalized medicine, where the diagnostics and treatments are tailored to the condition and the patient desires. So what's actually in our guidelines is that clinicians should perform additional testing in patients considered for surgical interventions if they have a myriad of other conditions, as we've mentioned, like the inability to make a definitive diagnosis, the inability to directly demonstrate stress incontinence on physical exam, which can happen, we know, for a variety of reasons, suspected neurogenic lower urinary tract dysfunction, or overactive bladder, which brings us to this OAB guideline. So again, for patients with idiopathic OAB, similar thoughts apply. But these patients are rarely isolated OAB and oftentimes have comorbid conditions which are really driving the overactive bladder, such as pelvic organ prolapse, voiding dysfunction, things that necessitate further evaluation. Now, our guidelines, and these guidelines in specific, are driven by the need for primary care providers to begin evaluation and treatments and expedite referral to an appropriate specialist. So the guidelines panel understands we shouldn't be doing advanced diagnostics in every patient or even in many patients, but they've given us great latitude, and it is an extraordinarily rare patient that doesn't need some type of diagnostics outside of the very basics prior to undergoing an invasive procedure.
Great, thank you. My practice is very similar to your practice in terms of utilization of urodynamic studies, Melissa. So, dear colleagues, we have prepared with Dr. Kaufman some questions just to understand your daily clinical practice. Please answer these short, easy questions just according to the real clinical practice, please. So the first question is, uncomplicated or index patients constitute the majority of female stress urinary incontinence cases in my practice. If you agree with that, please say I agree. If you do not agree, if the uncomplicated patients constitute only the minority, please say I do not agree. Now, are we going to see the results here? Yes.
It is. Wow.
Yeah,
Amazing.
it is here. Okay. So, Melissa, actually 56% said I agree, which means the majority of patients they see are uncomplicated patients, whereas 44% of our audience, we have a quite good number, 116 colleagues listening to us, they do not agree. So how would you interpret these results?
I mean, this is very interesting. You know, even for uncomplicated patients, like sometimes we postulate that urodynamics won't change management, and occasionally that's true, but even sometimes for something that appears relatively straightforward, and I know this is specific about female urinary incontinence, but if we think about things like post-prostatectomy incontinence, which has traditionally been treated as a stress-only condition, we really recently looked back at our population and found that a substantial number of therapies were directed at the bladder or combined with stress incontinence procedures that can really enhance outcomes. So this is fascinating that many of the providers on the call really have the majority of their patients with uncomplicated index procedures.
Yeah, even in the value study, the ratio of uncomplicated patients was only 33%. If you are working in a tertiary or referral center, then it may come down even to 5% or less than 5%, depending on the complexity of the patient you see. I think I see a problem here in defining uncomplicated patients. Is it only like recurrent urinary incontinence, but maybe we have to also consider the bladder volumes on bladder diaries, any discrepancy between the symptomatic findings and the signs and physical signs of the patient, like uroflowmetry patterns. So there are so many things that we have to consider, and we have to be really careful in defining our patients as complicated and uncomplicated. Would you agree with that, Melissa?
I would agree is we don't really have a complete definition of what index patient actually means. Is this a patient probably who's just never undergone a procedure before, but it doesn't mean that they don't have some mixed symptoms or comorbidities.
Okay, thank you. So let's move on to the second poll question. Please select the most appropriate statement that fits your practice prior to surgical treatment of stress urinary incontinence in women. A, say, I usually do multi-channel urodynamic studies. B, I only do multi-channel urodynamic studies in complicated cases. The last option is I never do multi-channel urodynamic studies prior to surgical treatment of stress urinary incontinence.
What do you predict?
I predict B as the most prevalent answer from our poll. Let's see. What do you think?
I agree, but I'm also thinking maybe we're going to get another curve that looks very similar across each one of the.
Okay. Now. So almost half of our group, I see 46% versus 44%. And there's only 10%, let's say. I think this is something that we have to, let's say, pronounce. Only 10% says, I never do multi-channel urodynamic studies. The rest of the group, half to half, says they almost do urodynamic studies on every case, or they do urodynamic studies only if the patient is complicated. So any comments at this point, or?
Well, when we embark on these studies, we really do it just with a question. And the question always is, what is the information that we need to optimize outcomes for this patient? And so although there's many stress incontinence procedures we've termed minimally invasive, right? They're outpatient procedures, they have limited incision. The impact of treatment in the absence of a really clear diagnosis is anything but benign. So when we look back, we talked about the value trial. We can look back on our Thomas trial too. It's a really pivotal trial looking at mid-urethral slings. Even patients who had really good objective outcomes, the subjective outcomes were not as robust. So 5 years out, 80 some odd % of mid-urethral slings still had good continence, but they didn't have good patient-reported outcomes. That was in the 60s because the process of surgery, recovery, potential complications was still there. So giving the patient information and fading them to poor outcomes and further invasive interventions by incorrect diagnosis is what we want to try to avoid.
Exactly. And last question. Please select the most appropriate statement that fits your practice before proceeding with invasive treatments such as botulinum neurotoxin A or neuromodulation for refractory urinary incontinence, urgency urinary incontinence in women. A, I usually do multi-channel urodynamic studies. B, I only do multi-channel urodynamic studies in selected cases. I never do multi-channel urodynamic studies. So this question refers to the refractory OAB patients. So when you want to proceed with an invasive treatment, such as botulinum neurotoxin or a sacral neuromodulation, do you perform urodynamic studies or not? Maybe in selected cases, maybe in all cases, maybe in none of them.
Interesting.
Okay. Now, okay. I think the answer here is more solid compared to the previous questions. And the majority of our audience voted for the first option. They do multi-channel urodynamic studies before proceeding with invasive treatments for refractory OAB.
I'm going to agree, because in this case, the surgical interventions and the risk profile of doing advanced therapies in this space are very profound. And, if it was me or my family member, I'd prefer to have all the tools at use available to make sure that the appropriate diagnosis is made, instead of just seeing what sticks when we throw something to the wall. We really need to expand evidence-based medicine. And in this situation, like urodynamics, is important data to drive these interventions. And the other thing that I'm finding more and more these days is, in the current environment, there's so much information online. So patients are more knowledgeable, they're more sophisticated, and they're coming at you with a background. And this advance in medicine, it really engages patients more in their own treatment and their own recovery. So urodynamics is part of that picture, and our levels of health literacy are increasing. I use it as a fundamental tool to objectively demonstrate to patients a correlation between the symptoms that they're suffering along with expectations for treatment. So it can be very powerful in this space.
Exactly. So I agree with you and with our audience.
And we have a number of really interesting questions already in the chat. I don't know if we want to embark on taking a few of those before we launch into the cases. The first one was clarifying the uncomplicated stress incontinence. And I think this is where we look into what is that index patient and how very rare it is. And so I would say that stress incontinence associated with prolapse or associated with mixed symptoms would not be your index uncomplicated patient. Patients who've had prior interventions, who have prior other comorbid conditions, would not be considered index. So again, that's a very rare situation. I think we've gone through a little bit about how we use these as gold standard. We are going to discuss some of the key parameters that are measured during urodynamic testing and how we use those, and we'll get to some of that in these cases. And also whether this is just versus a clinical diagnosis. Again, that's just for an index patient, using, if you only have in an index patient that's never had any other interventions, if they demonstrate stress incontinence. And let me bring forth that I think all our guidelines note that a physical exam that demonstrates stress incontinence is mandated. You need to be able to demonstrate that before you move on to an aggressive intervention, an invasive intervention.
Exactly.
Yeah. Go ahead.
So, Melissa, I think we will just touch this issue during our discussion in the coming cases. Can you please just proceed with your case now?
Yes, I'd love to discuss. When I'm looking at some of the next questions, they really do walk along into some of the answers that we bring forth in the cases. So I'd love to discuss some actual patients and get your insights on how we might utilize or not utilize urodynamics to help with management. So next slide. This first case I have is very common. It's a 62-year-old woman. I think it's a classic situation. She came to see me with mixed symptoms. So she had urgency and stress symptoms. And it's very difficult to delineate either from her history or my questioning exactly which one is predominant. Sometimes she tells me she leaks without any awareness, but her most bothersome issue, and this is really critical, is that we look at what's bothersome, is when she's active. So when she gets up, moves out of bed, when she does any physical activity, she's really, really bothered by all these symptoms. Now, fortunately, we did an exam. She had urethral hypermobility. She has a positive supine stress test. I didn't even need to stand her up to check. It was supine. And thankfully, her residual was 0. So in this situation, because she has leakage without awareness, she had urgency symptoms, I went ahead and trialed her on anticholinergics. I think we also trialed a beta-3 agonist as well. And although both of those decreased a little bit her urgency symptoms, she had continued issues with incontinence that just weren't resolved. So is she someone that you're going to move forward to an advanced therapy? Are you going to treat her urgency with third-line therapy? Or are you going to treat her stress with a sling or something, bulking agent at this point? Or what else are you going to do based on the physical exam and the findings that I have here and her failure of anticholinergics and beta agonists?
Melissa, thank you very much for bringing this case, because this is a very common situation, actually. This is not a marginal case. This is really a very didactic and common case that we face commonly in our daily practice. Well, to me, this patient needs certainly a multi-channel urodynamic study because of a couple of reasons. First of all, I'm very careful in patients with mixed urinary incontinence as a symptom, especially. And this sentence here, leaks without awareness of sensation, just draws my attention here and tells me that I have to be very careful in selecting the specific treatment for this patient. So this lady with this positive spine stress test associated with urethral hypermobility, but with mixed up urinary incontinence, it certainly needs a multi-channel urodynamic study before proceeding with any type of invasive treatment.
So her detrusor overactivity contractions are associated with leakage. They're associated with a sensation of urgency. But in addition, every time we asked her to do a straining maneuver with cough or Valsalva, she also leaks. And she has a modestly low leak point pressure of around 63 centimeters of water pressure. So, and then when we finally get to the pressure flow study, she has what I believe is detrusor underactivity. So in this patient, although she can empty completely, she doesn't give a really robust detrusor contraction. So Next slide. So now we've got this situation where a patient has overactivity during filling, underactivity during emptying, as well as stress incontinence. So now what we thought was complex already is ultra complex. So with this urodynamic tracing and knowing her symptom bother is based on those stress symptoms, how might you counsel her regarding the next best steps?
You know, the guidelines are now changing their recommendations, excuse me, and they are also including now the urodynamic studies as a valuable tool in guiding our patient counseling, our preoperative patient counseling. And I think this is a very good example in this regard. At the end of the day, you may still perform the same operation on this lady, but your preoperative patient counseling may be different in a lady with such urodynamic findings. So she has a urethral hypermobility and stress urinary incontinence. It is likely that the low amplitude detrusor overactivity may occur secondary to trigonal or urethral irritation here. And so I would like to address, for that reason, the stress urinary incontinence on this lady. And since she has a urethral hypermobility, I would prefer to benefit from her hypermobility, and I would recommend a mid-urethral synthetic sling or a single incision synthetic sling on this lady. Just to open a parenthesis, I would like to mention that in the treatment of hypermobility associated stress urinary incontinence, we do not have to treat urethral hypermobility. We just benefit from the presence of urethral hypermobility. In many patients, the urethral hypermobility still continues after surgery. And we also know that there are many people, many women with urethral hypermobility and with no stress urinary incontinence. So just I wanted to mention this important point, but here I would like to go for mid-urethral sling surgery of any type that would benefit from the urethral hypermobility. But I also would like to discuss with the lady that after surgery, she may still need some additional treatments if she has, for example, still urgency or overactive bladder symptoms. She may still need to be on some medications, although they did not help preoperatively. They may help her after the operation, or she may have some difficulty in emptying her bladder, and she may have a high residual urine. Therefore, I would be very careful in performing a surgery completely tensionless for this lady.
Yeah, I think those are very insightful commentary, particularly your thoughts about hypermobility and the real contribution that it has to stress urinary incontinence. And I split the difference and chose in her a single incision sling for the same reasons, to try and avoid any obstructive postoperatively, and concur completely that in many instances, some of that urgency component will improve. Maybe over 50% of the time, when that vesicourethral reflex is suppressed because the urine stops dropping into the proximal urethra and avoiding contraction. I also counseled her extensively that if the urgency component was not accommodated following alleviation of her stress, that we may need to continue medical therapies or even move forward with advanced therapies. So this entire case was really instructful for me to be able to interact with her expectations, like what was most important to her, and to have these functional studies to help engage her along the treatment plan. She understood what was happening, and we made a shared decision together with this information. She fortunately did very well with her mid-urethral sling, single incision, and most of her urgency component was relieved, and that was able to be accommodated for with the medication.
Melissa, there are very good questions, interesting questions from our audience.
Many of them.
Regarding this case, and also general questions. Regarding this case, Dr. Majid asked, neuromodulation will also be of benefit for detusor overactivity mixed with detusor underactivity. Would you like to comment on that?
I concur, and I utilize this extensively for both of those situations. So someone that may have non-obstructive urinary retention, so not one that is associated with any type of pathological obstruction, say a prior sling, or who may have some pelvic floor dysfunction and very difficult and almost non-neurogenic urinary retention. This patient population is an excellent candidate for neuromodulation. Now, in her particular situation, and there was another question here where it asked about how we use these studies to drive what's going to be the best therapy for this patient. So in her particular situation, her studies definitively showed detrusor overactivity and stress incontinence, but what we relied on was what the patient's most bothersome symptom was. Like the intervention was going to be based on her most bothersome symptom. Now, in many instances, if we had done this study and had not demonstrated stress incontinence either on her exam, although she did, this patient did, but if we had not demonstrated on exam, or she'd had exceedingly high leak point pressures, which we can talk about as well in the next case, then perhaps we would have moved forward with a third line therapy. And yes, in her situation with underactivity and overactivity, I concur that neuromodulation is an excellent, excellent adjuvant.
Yeah, so really, I mean, many thanks to your answer and also to our audience with these great questions. Can you please just continue by commenting on pelvic floor muscle training and biofeedback for this particular case?
So in most cases, particularly for all three of these situations, patients who have difficulty relaxing their external sphincter, who have non-obstructive urinary retention, patients who have detrusor overactivity, as well as patients who have stress incontinence, can all benefit tremendously from pelvic floor muscle training, either with a provider who specializes in pelvic floor physical therapy, or they can learn many of these on their own. But I always try to engage them to have therapy with a pelvic floor physical therapist so they can understand, one, their anatomy, and two, how this relates to the symptoms that they're having. And it really helps optimize any further interventions. Now, is it going to completely cure a patient that won't then require further therapies? I find that is more of a rare situation, but it absolutely will help them manage. And I think it is mandated in many situations, and it's incorporated in our guidelines. I mentioned incontinence after prostate treatments before. It's mandated in our guidelines that we advance pelvic floor physical therapy before surgical interventions and after surgical interventions in order to optimize patient outcomes.
Yeah, exactly. I mean, according to the ESTER systematic review, the chances of a complete cure in the long term after pelvic floor muscle training is lower than 3% in that patient group. There are two urodynamic questions. The first one is she may have an ICD because of low ALPP. If I may answer this question, actually the leak point pressures are not, let's say, precisely recommended to delineate ICD or not, because there's a huge overlap here. So we should not only decide just solely looking at the ALPP here. But you're right, who said Dr. Alamiri, you're right, she may have an ALPP. And if you look to the literature, some studies have shown it as an independent risk factor for poor prognosis after surgery, but according to some studies, it is not. So there is a controversial finding in the literature. But we know that hypermobility of the urethra is a good prognostic factor for our mid-urethral synthetic slings. So in that case, if there is urethral hypermobility, I think the mid-urethral synthetic sling is a good case, but you're right, ICD may be present in this lady. And the other question, Melissa, did you answer that already or not about the stress-induced detrusor overactivity related stress urinary incontinence here?
Oh, we touched on it.
Excuse me?
We touched on that when we talked about that vesicourethral reflex, but I wanted to go back to your topic about the Valsalva leak point pressures. I concur it's a very arbitrary cutoff point. To say that below 60, there's intrinsic sphincteric dysfunction, and most likely combined with other findings, if there's no urethral hypermobility, then certainly low Valsalva leak point pressures will really constitute almost gravitational incontinence, and patients are more likely to be readily cured with a bladder neck procedure than what we would see for mid-urethral sling. But we also, there was another very interesting question in the chat here about bulking agents in this population. So here's a patient who has hypermobility, and so not what we would consider typical ISD, although her leak point pressures kind of are right there in the middle. Would you embark on a bulking agent for this patient as opposed to a mid-urethral sling, with your thoughts about the importance of hypermobility?
Yeah, I mean, I don't think a bulking age for a bulking agent, this patient is an optimal patient. But there is another question. I'm really having a hard time in following the questions. There are so many questions.
It's
It says
fabulous.
it's fabulous. I'm so happy. Just connected to this question that you just asked me, synthetic slings are unavailable in the UK. The other issue is whether she may develop voiding dysfunction if she has detis or underactivity to begin with. Exactly. I mean, if we don't have a synthetic sling, of course, we surely go. I wouldn't go for a bulking agent in this lady. I would go to an autologous fascia mid-urethral sling, not a classic pubovaginal sling, but like the Chris Chappell group described, sling on a string technique, just to put a autologous fascia under the urethra. Of course, we can discuss. I can't say anything against bulking agents here. But the patient has to know that the success of bulking agents in this particular case is lower compared to a autologous fascia mid-urethral sling.
I agree. We also use mid-urethral non-synthetic fascia, autologous fascial slings with success. It's obviously in many instances worldwide, there has been a decrease in utilization secondary to many of the issues that have come on from the prolapse mesh. And we, of course, do see a unique set of complexities associated with mesh mid-urethral slings. But back to the point of the bulking agent, none of those studies were actually done in women who had hypermobility. So that's really where this drawback comes in. Might it work in some of these patients? Of course, but none of the studies that demonstrate efficacy were done in women with hypermobility. It was like an exclusion criteria that their hypermobility had to be somewhere less than 30 degrees. So although it may work, there may be some diminished efficacy in that situation.
Now, great. Thank you, Melissa. So there is also a couple of questions about local estrogen treatment. Can you also please just briefly comment on that?
So many of these women have signs and symptoms of the genitourinary syndrome of menopause. And this is a hormonal state that is diminished of all the different types of hormones related to sex steroids, including estrogen and androgens. It is so critically important for treatment in a patient who is menopausal or even perimenopausal to have adequate treatment of local tissues prior to any surgical interventions. There is minimal evidence, although there is one Cochrane review that may suggest some improvement of symptoms such as stress incontinence with topical treatment with estrogens, not systemic treatments. But overall, there is therapies, there is data to suggest that some of the overactive bladder symptoms, and we certainly know that recurrent urinary tract infections are mitigated. From a perspective of vaginal health and healing from any prior interventions, I think that it is mandated in many patients, and that would be the majority of patients, that we think about moving forward with vaginal application of low-dose estrogen. Now, there are black box warnings, particularly on the Food and Drug Administration in the U.S. for utilization of these estrogen products. But I will tell you that we are embarking on and developing guidelines for genitourinary syndrome of menopause that should be released next year And this patient population is prime for utilization of topical local hormone therapies.
Thank you very much, Melissa. We better move on, otherwise we will finish our webinar with just one case.
One case.
Yeah. So the second case is also a mixed urinary incontinence case. This is a 67-year-old lady with mixed urinary incontinence, but this time with prolapse. She experiences mixed urinary incontinence for 5 years. She reports it to be urgency predominant. 3-4 pads per day are used. She has been on antimuscarinics for 1 year, and she reports partial response. On physical examination, her ICS standard stress test is positive, urethral hypermobility is present, and she has a grade 2 cystocele according to Baden-Volcker classifications. Her PVR is 60 milliliters. Just before proceeding, how would you just plan your management at this point, Melissa?
Yeah, this is a great case, and there's really two different thoughts.
Your sound is gone again.
Am I back now?
Yes, you are
Okay.
back.
So there's really two different thoughts here. Of course, our guidelines might defer us to just moving forward, even with advanced therapies for her urgency component, because she's met all the criteria for urgency predominance and she's failed medical therapies. And despite the fact she has a positive stress test, many would just promote not utilizing any further functional studies and moving forward. But there's two things here: mixed symptoms and the physical exam findings with a grade 2 cystocele, which was done in a supine position. So if you stand her up and you stand her up at the end of the day, that's probably a grade 3 at least cystocele. So then it becomes obstructive. It becomes more of an issue. So further investigation is really mandated. And although she doesn't promote bother with her pelvic organ prolapse, it can certainly be impacting function. So I really advocate in this situation for a multi-channel urodynamics to see whether, is this just overactivity? I'm going to counsel her about the best practices would be performing the procedure, not just with her sitting in the position that she has typically, but also with the prolapse reduced, just to make sure that there's nothing that's contributing with regards to that cystocele. This is really a range of expectations. We see it very, very frequently following hysterectomy, vaginal delivery. But when it's comorbid with these urinary findings, there's a very specific technical consideration to do urodynamics, both without the prolapse reduced and with the prolapse reduced, and doing that study twice just to make certain that we have the appropriate information. Great.
Thank you, Melissa. So this is the urodynamic study that we did. Again, cystocele reduced during the urodynamic study. The cystometry didn't reveal any abnormality other than a positive stress test with Kaufman and Valsalva after filling the bladder with 300 milliliters. So she has a urodynamic stress urinary incontinence. Her pressure flow study is with Qmax 21 milliliter per second and with a P-deficit at Qmax of 15 centimeters of water. So what do you think at this stage about the treatment of this lady?
Yeah, again, I'm not going to use that lead point pressure. As we already discussed, it's a really blunt measure, and I'm not sure that it's going to drive my therapeutic intervention, whether it's going to be what type of sling I'm going to use. But overall, in my practice, I am very pleased with this urodynamic tracing, particularly with her compliance and capacity and volume. And I think that one of the things I might propose for this patient is use of a pessary. And we can use an incontinence pessary, right? So we can reduce her prolapse and control her incontinence and make sure that as long as she's not allowing her bladder to overfill, it's almost like a real world test of what's going to happen, a proof of concept of what's going to happen when we do a surgical intervention. Because in this patient, I'm probably most likely to counsel her about both a prolapse repair and mid-urethral sling, being that she had such excellent parameters during her prolapse reduction on her UDS. And so that with good storage, I would counsel her, we can trial an incontinence pessary, which will do both, and then move forward with surgical interventions.
So this lady was not happy with the idea of the pessary, and she wanted.
That's true. That happens quite frequently.
Yeah. So if you would like to go for a surgical or other option, what would you recommend for this lady?
Yeah, most likely I'm going to offer her, since their first time prolapse repair, an anterior repair. So I do a site specific repair, transvaginal, and a mid-urethral sling in the same setting.
Okay. So that is the presence of a prolapse is a good indication for you for multi-channel urodynamic studies. You already said this, but Melissa, just to give
absolutely. Absolutely.
Oh, great. And what we did on this lady was a mid-urethral synthetic sling together with this anterior vaginal wall prolapse repair. I don't know if there are any options for this lady that you may suggest.
So, and in this situation, again, because of the hypermobility, I'm not going to offer bulking agents because of the potential for a diminished response. And she could also be a candidate for an abdominal repair. I would tend to do this first as a vaginal repair, but she's also a candidate if you wanted to do a sacral colpopexy. This would be a very common procedure for her. And I believe that either one of those interventions, but I do believe that she needs repair of the prolapse at the same time that she undergoes mid-urethral sling.
There's Dr. Shahla asking, but she has no symptoms of prolapse, neither significant PVR. Why prolapse repair provided type 2 little bit controversial for surgical repair?
So it definitely, when we do the urodynamics, he only showed you the one that we did with the prolapse reduced, but you'd have to compare that to the one with the prolapse not reduced. And there you're going to be able to differentiate and see that she may not have the same type of storage symptoms. She may have obstructive symptoms, and that this may continue to progress. So I concur. This is a shared decision-making and one where we do that urodynamic study, both with the prolapse not reduced and one with it reduced, and then be able to have that conversation with the patient. Even if she is not presenting with overt signs from the prolapse, again, what we see when she's in a supine position and what may manifest at other times may be different.
Exactly. I mean, what we see, the question has certainly a very important point. I agree. And I thank Dr. Shahla for the question.
Absolutely.
Something that we do not like to see after surgery is a swan lake abnormality if she has a cystocele, which actually worsens with time, and after a mid-urethral synthetic sling, this position is worsened. So it is something that we have to discuss preoperatively with the patient. And so repairing the anatomic defects together with the urinary anti-incontinence surgery is usually recommended. However, we have to, of course, discuss the pros and cons for that. And I agree that a non-symptomatic prolapse, of course, is not in the indication of a prolapse surgery. But in that case, with a PVR with 60 milliliters preoperatively and with the physical findings and also urodynamic findings here. I think this is something we have to discuss with our patient preoperatively and decide together. So there are other questions actually, but there is a Q&A option. Roger is warning me, but I cannot see that. Melissa, can you reach the Q&A box there and see if there are other questions? I couldn't reach the Q&A on my screen, maybe because I'm running the slides or maybe because I'm not knowledgeable enough with this Zoom program here. And
yes, and there's a marvelous amount of questions regarding the impact of physical therapy on these types of symptoms. And again, although we're not physical therapists, we certainly advocate in every possible situation working with a physical therapist to try to ameliorate all these aforementioned things: urinary retention, urgency incontinence, as well as stress urinary incontinence. And so doing these types of urodynamics in these situations, I think, can inform both our ancillary providers, so those that are collaborating in care, so we are able to better direct. So in many instances, for example, if I have a patient who has, non-obstructive urinary retention, and they have pelvic floor hyperactivity, and I find that out on the urodynamics test, and I send them along to physical therapy, I don't want the physical therapist saying, oh, they're coming in with incontinence, they need pelvic floor strengthening, because that's the exact opposite of the type of therapy they actually need. So using blanket statements about this patient has incontinence and sending them to one of our collaborative providers is not helping the patient. And so having this information really helps inform both of us, physical therapy and the physician, as to exactly the type of therapy that we need in order to optimize their outcomes. There's great. Also, again, some questions I think that we've already been over about utilization of pessary and bulking agents to help with these types of patients.
Yeah, so, another good question comes from Dr. Mehmet. Which surgery is done firstly during operation? Mid-ureteral sling or cystocele? The prolapse is always repaired prior to sling surgery, and I would suggest to do the operations through two different incisions, so do not combine the two incisions, otherwise it may be difficult for you to place the sling in the correct localization.
I agree 100%. That's exactly the way that I do those surgeries as well.
Yeah. There's another question from Dr. Francis Muriti. Would you do subureteral buttress during anterior repair? Melissa?
So I don't typically do that. That's where I would make the separate incision and do the mid-urethral sling, because again, my anterior repair incision is running from the bladder neck to either the cervical cuff or the apex of the vagina. So it's not suburethral. So I don't really have an option to do a separate suburethral buttress at the same time of plicating tissues. So I will do a separate incision, or, possibly if you are abdominal and you're doing a sacrocolpopexy and you perhaps doing laparoscopic or robotic sacrocolpopexy, it's still advocated to perform a Birch procedure at that time. That would be another option if you didn't want to do any type of mid-urethral sling or didn't have the opportunity in that setting. So doing two abdominal operations with a suspension, a retropubic suspension, would also be another option.
Thank you. Let us please move to our last case, just to finish all our cases on time. This is a persistent stress urinary incontinence after mid-ureteral sling. This is a nightmare for many of us, really a big challenge. This is a 50-year-old lady with persistent stress urinary incontinence after TOT. She has 5 vaginal deliveries. And on her current physical examination, she has a cuff stress test. Now she has a limited urethral mobility with less than 30 degrees, no prolapse, no mesh problems, normal ultrasound, urinalysis, and biochemistry. Her uroflowmetry is completely normal. PVR is insignificant. She has a bell-shaped curve. Now she seeks a dryness. Melissa, what would you be
It's
your
such a difficult
recommendation?
situation. These patients who have recurrent or almost, this might even be like persistent leakage after undergoing a surgical intervention, are very complex dilemmas. And one is because you're trying to mitigate patient expectations. They've already gone through surgeries, which were meant to not to ameliorate their incontinence and be curative. And how they had incredible hope, right? And now the disappointment of having absolutely no improvement. So in this patient population, and we see it more than we would like to admit, that are really particularly afflicted after mid-urethral slings, it is sometimes, and this is very rapid, but most of the time we see this as a gradual bank over time. One could assess there may have been some type of technical considerations specific to her sling, but since there's no mesh erosion, no mesh extrusion, the urethra appears well supported, despite the fact that she has a positive test. This really brings me to consider that maybe there was not a correct diagnosis, but perhaps we've treated someone with mid-urethral sling technology that should be robust, but the real problem lies in bladder storage, even if that's not what the symptomatology that she's expressing. But there's really nothing that's going to give us this information or drive our therapy more definitively than multi-channel urodynamics. And I find that these patients are exceptionally willing to undergo these procedures to ensure that we are making the next best steps and the next best clinical decisions. So in my hand, she absolutely requires urodynamic testing before we do anything else. No further interventions until we have the information.
Okay, now one question from me and one question from the audience for you, Melissa. I would like to ask you about the role of translabial ultrasound to localize the mesh here. I mean, if you have any suspicion about the a wrong localization of the mesh here, do you perform in your clinical practice a translabial ultrasound? And the audience, there are many questions, actually more than one, about the lock setting. Actually, do you think, for example, in this case, before proceeding with urodynamic studies, is the loxetin available for the treatment of urinary incontinence? I don't know. So if you have, what do you think about using the loxetin in that case?
So ultrasound is just a really spectacular option. And I have found, at least in my practice, that you have to have the appropriate colleague and provider that's going to be able to perform that. So we don't have that option in my own clinic, and I have to send them out for referral in order to get that information. And so the yield in the referral is very low. And so we don't have the option of utilizing that. But if you're able to perform translabial ultrasound in your clinic to determine the position of the sling, it's interesting. What happens if we do that on the next 100 patients, whether they have symptoms or not? And is it going to matter? Is it going to matter where that lies? Because what we found is that patients, and I agree that the location is very, very specific, and so we did discuss a little bit about the technical aspects, but what we found is when we went back and looked at patients who had obstructive pathologies, they were mostly at the bladder neck. So perhaps this is more distal and in the wrong location. But unfortunately, in my situation, I don't really have the option of doing translabial ultrasounds to determine that before we move forward to look at functionality. And I'm not 100% convinced that the location is always always correlates with functionality.
Any comments about duloxetine?
No, I don't. You tell me.
Yeah, I mean, the loxatine, according to the guidelines, can be used in the management of stress urinary incontinence and also stress predominant mixed urinary incontinence whenever it is licensed to. So you have to be in a country where it is licensed for the treatment, but we have to know that the complete cure rates are very low. And so it may decrease the severity of urinary incontinence, but the likelihood to cure it is almost none. And there may be, of course, side effects, but of course you may discuss it. We use it especially in hopeless cases, let's say, to just decrease the severity of urinary incontinence. But for a long-term treatment, I think you have to discuss the pros and cons very well with the patient. So we did the urodynamic studies, if I may proceed. And I think you see the urodynamic study on screen. So Melissa.
Yeah, I'm surprised. I'm absolutely surprised. I would have suspected some degree of instability. But now I've discovered from your studies that she has the same low leak point pressure and lack of hypermobility before her sling. And it wasn't just that the sling didn't stabilize her urethra. She has some ISD, some sphincteric dysfunction. And this is not unusual. Didn't you say she had 5 vaginal deliveries? So I really believe it informs my next steps in a situation, because in my hands, I would strongly recommend at this point an autologous fascia pubovaginal sling for her stress incontinence. She's demonstrated on her pressure flow. She's not likely to have obstruction. She has excellent detrusor contractility, and that a bladder neck sling will both assist her incontinence. And I'm really, her overactivity is, she may worsening some de novo urgency after we do a sling, but I'm actually less worried about that. And that would be a discussion that we would have as a shared decision, that we would be able to mitigate some of those issues afterwards, because we do know that it is a higher risk for de novo urgency. And the question really becomes like, what do you do? What did you choose to do for her? And what did you do with the mesh that's in there already?
Exactly. And there's already a question regarding that. So what we did was actually an autologous fascia pubovaginal sling for this lady. Of course, after a good patient counseling about the possibility of avoiding dysfunction afterwards. But I think still it is the best treatment, one of the best treatment options, let's say, to treat ICD or midurethral synthetic sling failures. We know that most of them are due to ICD. Of course, there are other points, important points that we may discuss. For example, would you go to remove the midurethral sling when you do the pubovaginal sling? What will be your policy during surgery? This was asked by our audience.
Okay, so there's really 2 schools of thought. One is to remove, because it's a foreign body, which remains a risk for the patient. And I'm going to be right in that area because of the dissection that's going to lead me through where the flap I have for the pubovaginal sling. So if I think that it's a risk and it may be prudent for me to at least remove a portion, you can do that at the same time. But it's really an individual surgeon's discretion and what you're comfortable with. I do believe it puts the patient at an elevated risk of urethrotomy or needing a urethral reconstruction, only if they're going to benefit from this. So I only do it if it presents itself and I feel that the foreign body somehow puts them at greater risk.
Exactly. There is one point. She has detusser overactivity. Autologous slings are, in the most cases, obstructive. It's not a very good option in this case. There is no detusser overactivity, actually. What you see on the detusser pressure here are actually all the cuff tests. Maybe some artifacts is seen on the detusser pressure. So I wouldn't call it as detusser overactivity. So what I do, I agree with you, Melissa. When I see during surgery in front of me the sling, of course I remove it. But if I don't see it during my surgery, then I wouldn't, very much bother myself. Of course, just if there's no problem, mesh-related problem. And this lady tells us that nothing has changed after her TOT procedure. So we are not talking here about an obstructive TOT or misplaced TOT. Basically, the lady had an ICD and immobile urethra beforehand, prior to first surgery. So maybe a TOT or a TOT was not the best option for her from the beginning.
Yes, and there's a number of different questions also about artificial urinary sphincter. And so for women with intrinsic sphincteric dysfunction, AUS put at the bladder neck may be an outstanding opportunity. Again, you have to be in a place where this is approved by, advocated for. And in our situation in the United States, it's not approved by the Food and Drug Administration that oversees our procedures in order to implant. So it's very, very rarely utilized outside of situations for neurogenic patients. But when we do utilize it, and I think that there's going to be new innovations that are occurring in the artificial urinary sphincter space that will make it more palatable and easier for women. And when we do utilize it, allow me to caution, this is not a vaginal procedure. It is a retropubic procedure where the sphincter goes at the bladder neck, because a vaginal procedure would put them at higher risk for all the different types of complications that we might see from having a foreign body in that environment, such as extrusions and erosions. So it is a bladder neck procedure. It is not a transvaginal procedure.
Okay, thank you very much, Melissa. Well, I think we are at the end of our webinar. I'm really very happy with this nice discussion. Melissa, it's been such a pleasure and honor for me to be
Always.
with you, to be in this webinar. And I'm just passing our last case. And I would like to thank you and also the ICS office, especially Roger, for the great technical support. And I would like to thank you, Melissa, for being in this webinar with me. And I also would like to thank our audience. They were great. And thank you very much for being with us.
So lots of different options for urodynamics under the lens. So if you go to the ICS website, there are didactics on common questions, concerns. There's another one of these seminars on urodynamics in the neurogenic population. I saw several different questions regarding urodynamics there. And this one will again be available within the next week for you to view. And we really appreciate everyone's engagement, and your feedback is crucial because we want to continue to do these. We want to provide this service. This is about what it's all about, is us collaborating and determining the best strategies for all of us to move forward with our patient care.
Thank you. Have a good night or good evening to everybody.